I'll the introduction here, and as soon as I click OK on recording in progress. And so basically, we'll have three speakers today, and what we'll do is we'll hold all the questions to the end. So you can either raise your hand and we'll call on you to ask a question at the end of the talks, at the end of the first talk, each talk, and or you can type the question in the chat and we'll read it out. So first of all, if I can ask everybody to mute their mics until the question and answer session, that would be great. So we don't get any interruptions. And also, I just want to let you know that all three of these pilot projects that will be discussed today and presented are all funded by the NNE-CTR. They've already been funded. And also to announce that the next round of funding will be open on July 1st. And you can find details on the website. Just search NNE-CTR and go to the cores tab, and you should be able to click pilot projects and find out how you can also get some pilot funding for NNE-CTR. So we're really excited about these talks. First speaker today will be Tim Burdick. And Dr. Burdick is the Associate Professor of Community and Family Medicine at the Geisel School of Medicine at Dartmouth Health. And he's been a practicing rural family physician for the last 20 years. He's also Director of Informatics for the Northern New England Co-op Practice and Community-Based Research Network. Today, he'll be presenting the studies he's been involved in, called A Comparison of Low-Burden Data Collection Methods Using a Card Study on Primary Care, Telehealth, and Burnout. So, Tim, you're on the stage. Yeah.
All right. Thank you very much. And thanks to the study collaborators, and thank you very much to the CTR for funding this project. And we're glad to be presenting it today. The project is mainly focused around a research methodology called card studies and a comparison that we did among three different ways of delivering cards. The EHR and burnout component of this study was we needed to have some questions to put on the cards, and so that was sort of a secondary piece. So I'm really going to talk today about a primary care research methodology called card studies. So one of the issues that we face in family medicine and primary care internal medicine, pediatrics, is that there's often a lot of information that's missing in the clinical context, particularly around why did the clinician make a certain decision in this visit? Why did they provide a certain type of care? Why did they choose not to provide another type of care? And card studies provide a way of filling in that missing information and providing some data to help us understand some of the processes and decision making that happens. It also allows us to understand some items around patients and treatments that they receive as well, that is often otherwise difficult to get from electronic health record data. There are many studies going back decades that have been instrumental in changing clinical practice, reducing the number of CAT scans for patients with headache, reducing for ear infections, reducing unnecessary dilation and curettage after spontaneous abortions in women. So the card study methodology has been instrumental and very transformational in clinical practice. In the past, we used paper cards, and I'll show you an example of that, but very simply, 3x5 or 5x7 card, often printed on heavy card stock, and providers those would be pre-printed. Providers would have them in their white coat. They would fill out, check the check boxes or fill in a couple of questions. It might take a minute or two at the end of each visit. Those have been used for a long time. In 2022, a group based out of Eeghen in Oregon developed a way of delivering those cards through the electronic health record instead. And since then, there have not been any publications describing that methodology. And then there's also more recently a phone app, and there are no prior studies using the phone app before this one. And this is also the first time that these methods have been compared rigorously. With our funding, we were able to engage 3 different clinical systems: Little Rivers Federally Qualified Health Center in Bradford, Vermont area, the Dartmouth Health Heater Road Family Medicine Clinic, and multiple providers in a couple different sites in the UVM Health Network. We assigned paper or EHR-based or phone app-based cards based upon convenience. And this is the pop-up that happens within Epic Electronic Health Record. So if a patient is being seen and that provider is participating in the card study, this pops up at the visit. You click on the link to complete the survey. That opens up a red cap survey and you answer 5 questions there. It takes just a quick second to do that. This is what the paper card looked like. Again, a couple of check boxes to do, some Likert scales to circle. We tested this out and it usually took less than a minute to complete. So this was the paper one. And then this is the phone app. Same questions available on a phone app. You just tap the responses and that gets stored back to a HIPAA compliant server that we can pull the data off of. So the research question we had was to measure card completion rates for each of these different card delivery modalities. We did a post-card completion satisfaction survey to see whether clinicians felt comfortable using the cards and whether they would be likely to recommend using it again in the future. And then we also evaluated the cost of using these 3 different card tools. We used a Kruskal-Wallis test and Mann-Whitney test for comparisons in SAS. If you have questions about the statistics, I'm not the one. All right, briefly, this is what we found. We found that the paper, EHR, and phone app delivered cards were very much acceptable to primary care providers. They felt like it did not disrupt the delivery of clinical care. They found the cards easy to use and felt like they would want to participate in the future. So that was nice to see. We looked at card completion rates. Completion rates were quite high, regardless of delivery method. In fairness, we did have people who had volunteered and were very eager to participate in this process. Generally, we find that the case in other card studies as well. People sign up because they want to be involved, and the completion rates tend to be high. We did initially have some problems with the way the EHR pop-up was being delivered. We made some changes, and we think that in future card studies, we could get the EHR-based card completion rate up into the 80s or 90s% as well. Here in each of the paper, EHR, and phone app, there's 2 bars. The smaller bar on the left represents our estimated cost for this particular project, where we were doing about 100 cards in each of these modalities. And then in the yellow boxes, we scale that up and say what we think that would cost if you were doing a card study with 400 cards in each modality. And what we found was that the paper one is quite simple and easy to do, and the startup costs are low, but you have to take those paper forms and have somebody manually enter those into an Excel spreadsheet. And to make your data entry more accurate, you want to do double data entry. That staff time adds up, and there's a cost associated with that. And so the cost becomes a little bit more as you scale up the paper. And if you were to go even more, to 1,000 or so cards, that would continue to grow. With the EHR and the phone app, there's a little bit more involvement to get the study started, but it scales a little bit better, mostly on the data management side. For the EHR and the phone app, the data can be downloaded in a spreadsheet quite quickly and requires a fairly limited amount of data cleaning to begin your analyses. To date, we've presented at the NAPCRG, North American Primary Care Research Group, PBRN conference just a few days ago. And during that presentation, we went through some of the data from this project, and then we actually broke out and then gave the participants an opportunity to fill out. We had simulated patient encounters, and people filled out paper cards. We had one group filling out phone app cards and another group using the EHR REDCap based cards. And then there was some discussion about how they felt about those different methodologies. And one attendant came up to me afterwards and said it was the best workshop that they had ever attended. And we also have a publication that we submitted a couple months ago to Annals of Family Medicine that has received good reviews. They have asked us to make some revisions, and we plan on resubmitting that in the next few weeks. So I will stop there.
Thanks, Tim. So we have, so if anybody has any questions, you can raise your hand. But there is one question in the chat from Ben. And Ben, would you like to ask your question?
Sure. I had two thoughts. One was the design of this, were the same respondents given all three modalities, or are they separate groups?
For this, we did not attempt to control for provider to provider differences. So one group of providers had the paper cards, one group had just the EHR, and another group had just the phone app. So there's a potential.
You got the cranky providers in the in one arm.
Potentially, yes. That may be the case. If we scale this up with enough providers in each arm, that should wash.
And in years ago, we were using optical character recognition and scan forms, and kept the cost of paper data entry way down. So it occurs to me that that might apply here also.
Yeah, that came up at our workshop as well. We didn't consider it for this project, but in retrospect, it would be a nice modality to add. I think you're right. We also figured out that you could also just use REDCap, and you could take the QR code for the REDCap questions and just put that on like a little file card in each exam room and open that up through the QR code. And that would be a very easy, inexpensive way. And then again, the data coming back in through REDCap is already in the spreadsheet for you. Yeah, thanks, Ben.
Oh, right.
Nice.
Is there any other questions for Tim? Yes, Connie?
Hey, Tim, it's Connie. I know I'm on the author list, but nonetheless, I get to ask a question, which is, where do you think this is going next? Do you have a strong case to make for continued testing these methodologies, or a particular direction you want to go to move one of them forward? What happens next?
Yeah, I think the conclusion that we've had in both this pilot and also reinforced from the feedback from the 40 or so people in the workshop this week is that different clinics and different clinicians may be better suited to different modalities. So I don't think it's a pick the best. I think it's matched the right modality to the clinic and clinician.
Okay, great. Any other questions? So, fantastic. So, Janet, so I think you'll be introducing the next speakers. Is that correct? Yeah, you're on mute. Janet's on mute. Yeah, you're muted. Okay, great.
Dr. Van Eeghen is an assistant research professor at the University of Vermont Larner College of Medicine, and her research interests center around quality improvement in primary care, implementation science in healthcare organizations, and healthcare research. She will be joining the NNE-CTR leadership team as the Community Engagement and Outreach Core PCBRN liaison. Her presentation today is entitled Opioid Prescribing Patterns and Analysis of Secular Trends. Thank you. Connie.
Janet. Thank you, Janet. I will do the technology trick of turning this into a presentation.
Yeah, great, thanks. I was going to say, I couldn't hear you very well. Yeah.
Oh, okay, is this okay now?
Yeah, it's much better now. Yes, thank you.
Okay, thanks. I'm trying something a little bit different in my Zoom skills. I figured this was a safe audience, so if it isn't working or if something doesn't look right, let me know. But thank you, Janet, for that introduction. Pleased to talk about the results of our opioid prescribing patterns project, which was a project to use state-based data from a data source that's available in all 50 states. We were just focused on Vermont, New Hampshire, and Maine to monitor and visualize trends in opioid prescribing for patients of primary care providers who have chronic pain. I want to acknowledge the team that was just outstanding in helping me do this project. Particularly, I'm just going to pick a few people out. Marion Burke, who was the project manager for this, who was the glue and kind of the engine that kept us continue to go forward. Zoe Dowdier and Jennifer Raymond from Dartmouth Health's community sorry, I'm still practicing this acronym, Practice and Community-Based Research Network for the Northern New England area. And as well, they were just instrumental in helping the Dartmouth team put this project together and to help one of the clinics conduct the work. So thank you to both of them. And I also want to say thank you to Moira Mulligan and Douglas Pomeroy, who are patient partners on this project. And a salute to Charlie McLean, whose project I learned about when he was starting to do this about 12 years ago when I joined the UVM team. So thank you for listening to this and what our results are and what our next steps are going to be. I also want to say thank you, of course, to NNE-CTR for providing us with the opportunity, and the Northern New England Co-op, PCBRN, for making it happen as well. The National Institutes of Health was the funder, and you all know that already. And we had 4 participating clinics in Maine, New Hampshire, and Vermont. Issues around opioid. Yes.
Can you put the CTR
I'm seeing your slides.
slides?
You're not seeing my slides.
No, we're seeing a
Alrighty.
Word document.
That is awesomely bad. Okay, so let me try that again. And thank you. Tim knew enough to ask this question ahead of time. All right, this is the one I'm supposed to be on. Does this look better?
Oh, yes.
Yeah, a
Okay.
lot better. Yeah, great. Thank you.
Thank you very much. Okay, so apologies. As I said, I'm getting used to some new tricks here. So this is our project. This is our team. This is our acknowledgement page for the great organizations and programs that are helping us. So thank you, as well as to the clinics that were participating in this project. And now to continue on the point of opioid prescribing, we have a well-known problem that has plenty of epidemiological background to it, and saying that opioid use, some of which is based on opioid prescribing, is a problem, not just in our country, but certainly in our country and also in our region. We know already that there are particular factors that are related to increased opioid prescribing. There's been a strong move towards recognizing and treating pain, and what are our tools to do that? One of those is opioid prescribing. Patients have an expectation that their pain will be managed and controlled. Pharmaceutical companies market to prescribers, and they also market directly to consumers. So there's a lot of focus on, to what degree is opioid prescribing helpful in managing chronic pain? And then there are moderating factors that include regulatory pressures, standards from licensing bodies, the availability of drug monitoring programs, which we call PDMPs, which is the data that comes from pharmacies when a pharmaceutical order related to a control substance is picked up, insights from our overwhelmed criminal justice system, and a general decrease in patient demand as the awareness of the possible harms that opioid prescribing can cause. So there's a lot of pressure both for and in defense of protecting opioid prescribing. So we wanted to take a chance. This is a feasibility study, as in, can we get this done? We wanted to take the opportunity to look at 3 different states' PDMPs using statewide their statewide data, particularly their dosage data, protected in terms of patient identification, because we know that these data are available across the country, and so that we have the potential of saying, if we can use these data in a way to help monitor, we could provide a solution that is scalable and useful to many, many primary care providers. This method doesn't depend on the electronic medical record, so this is not a case of having to go to a vendor or do additional programming in your practice. However, it does require some work inside the practice. So there is a practice impact. And so we also wanted to collect provider feedback on what this felt like, whether it was useful, whether they would find this something that they could use usefully in the future. We also wanted to test a chart review data collection process, not collecting the same data, but collecting data that's not available in the PDMP. Data, for example, about did you do a urine drug screening test, or did you collect consent or an agreement for treatment? Did you check your PDMP for data before you began prescribing, as examples? So these were all pieces of data we couldn't get from the PDMP, and so we set up a different process to see how easy and feasible is it to collect these data from the chart. And then in addition to that, since the picture of pain management isn't complete without a patient perspective, we also asked our patient partners to help us look at those pain measurement tools that were being used by our participating clinics, and also to look at the literature and talk to experts about whether or not there were some that seemed preferable if we were going to move this forward into a wider research study based on these particular tools. So those were our 3 aims. And we're just finishing the study now and still writing up the end results. However, what we do know is that we had these 2 data sources plus the patient partners. The 2 data sources helped us identify what the doses were, whether it was co-prescribing taking place at the same time, and a kind of unique trick for prescribing of controlled substances is how many providers and practices were using 7-day increments. In other words, prescribing in 28 days instead of 30 days or some multiple of 7, to ensure that prescriptions would be due always on the same day of the week, and that cross coverage or weekend absences would not be likely to be a problem. And then for chart review, we were looking for the consents and agreements, the use of the PDMP, whether or not patient function was evaluated, risks, and how often they were being brought back into the clinic. And we're not going to do a review of clinic by clinic or provider by provider here. This was a feasibility study to get it done, and I'm going to jump to those results. We did offer some benefits. I like to consider what's going on for our participants. They're really important parts of any research study. We gave each of them a summary report of their opioid prescribing for each of their providers that was currently present and able to give permission, able to give them a picture of their measures of safe and effective prescribing and benchmarks, comparing them to other practices that were in the study. They also had the roster as a result of the study, which they could, if they wished, use for future either clinical or quality improvement purposes. And we compensated them $5,000 per practice for their participation in general. And then in addition to that, a total of $1,600 for their chart reviewers to do this study. So big thank you to the practices for going through that with us. We learned a lot just in participating with different practices who are differently organized. Here is an example report. I moved too fast, by prescriber. We have the individual, these are a little hard to read, I know, but at the bottom, these have all been completely anonymized and the results have been somewhat altered. So this is not a perfect picture of one clinic, but a good example of what we found. And if you look at each color bar as being one provider, and then you look at that provider's color bar over time, over the 6 years on the screen, you can see that there are some fluctuations as happens. And we learned from talking to those practices that things definitely change, that a provider who is prescribing leaves the practice, a new one comes into the practice with a slightly different style or habit of prescribing, or someone is taking on new cases, or they're rebalancing their load. So none of this suggests to us that there's a wrong acting provider. This suggests to us that there are stories taking place inside each practice and that these make sense when you look at the stories. They also show that providers differ in terms of how likely they are or the kind of patient population they have that is amenable to opioid prescribing. So, for example, one provider may have more of a time in where they visit the hospice, for example. Another may not do that kind of particular care. So we've got changes in the shapes of these, in the curves represented by these bars, and in the comparisons of these providers as they look to each other to say, oh, we're different. We're not exactly the same. So that was one kind of picture we gave each practice. And these are reflecting MMEs, those morphine milligram equivalents, and they are stacked by thousands so that you can kind of look up the vertical chart to see where they fall. We also did this for each practice, and in that case, we combined practice providers and prescribers into single practices. Here you can see 5 practices, some who have different histories in terms of how much history we could bring out of their PDMP. And again, you can see that there's a change in the shape of each curve, whereas the first practice goes up for a little bit, it then comes down. Another practice comes into the study and continues to go up, and then more recently comes down. Many of them are at below the 200,000 MME per year per 1,000 patients. And they all have a sense of trying to look at, adjust, and change what it is they're doing. It's as though, yes, people are aware of what they're prescribing, but they also have very different populations and stories. So here are the results, not by individual group, but what we learned from the study, which is if we wanted to use the PDMP as a source of data, we found that, first of all, it is feasible. All 4 practices were able to do this. And they were obviously practices that were interested in the project. So that was a piece of that. But they each had to, in their practice, ask all of their prescribers to download each one his or her own PDMP data, which meant that they had to spend a little bit of time at a computer on a PDMP screen. In Vermont, that's called VPMS. And what we had to do was ask them to download that in such a way that we could accumulate those data and then study them in a de-identified way. They reported afterwards, generally, as we collected their feedback, that it wasn't particularly burdensome. Some of them appreciated having a helper on hand to be able to get through the process efficiently, but they didn't, in some cases, even remember doing it. So I considered that to be a good thing. And they also said that these reports were actionable reports, that they were informative and pointed towards they're about history, so they kind of pointed them towards the future about what it is they're doing and how they are doing it. Some practices do have access to similar data, but we also heard that having access to similar data doesn't mean that those data are actually presented in a historical fashion where they could see their trends or do these kinds of comparisons. So the overall sense was, although they may have access to the data and they were familiar with these general trends, they also confirmed that this made sense for their practices. They didn't have data that looked quite as crisp in terms of its historical and comparative organization. Aim 2 was testing the chart review process. Again, every clinic was able to do this, train your own chart reviewer and help them collect data from the electronic health record. And we used into a survey tool. Staff made incredibly good efforts. Everybody really worked hard at this, but it was hard. They had to take several rounds of practicing sometimes, always with the result of saying, okay, now we know what we're looking for. But even then, they had to check back in and make sure, is this what this means? Am I looking for this in the right place? Sometimes because not every provider in a single practice documents in exactly the same way. And not every health record is, of course, set up the same way. So they had to kind of learn how their different providers use the health record and how those providers were documenting in that health record. Providers also told us that this wasn't particularly new information when we reported them about their consents, treatment agreements, drug testing, VPMS or PDMP use, that those were not new information, but he confirmed that the information was generally accurate, which was good to hear. But we did also hear that this was not something that is a easy to do function in a practice. It definitely takes extra work or an extra person outside the practice to help do that. And then third, we heard from our patient partners that the pain and function measurement tools used by those practices, while they were good in different ways, they were generally short, very specific about pain or activity or function, in some cases enjoyment. They didn't necessarily cover other things that our patient partners thought were important, like fatigue, or anxiety or ability to sleep at night, which they think plays very heavily into their management of their chronic pain conditions. So there were some pieces missing that they thought were important. And they ultimately, after talking with some experts and looking at the literature, did actually come up with a specific recommendation that the Promise 29 was one, and there are others, but was one well-established tool that they thought would be helpful. May be complex to use in a clinical environment without being integrated in the electronic health record, but very helpful from a research perspective, that would help inform the researcher about what the experience of the patient would be if there was an engagement in how do we change opioid prescribing in practice. So those are the results that we came up with. And we have, this is our last slide, we have some new directions that we want to take. Patient rosters are, for us, a part of the way we think about long-term, chronic disease management. So this is true, we know, for diabetes. This could also be true for managing chronic pain. Think of it as a panel where you know the size and scope of your panel, and you can benchmark, you can do quality reporting, you can do peer comparison. And when trying to accomplish that panel management approach, one of the possible sources of data, of course, your own electronic health record is a source of data, but a PDMP can be a source of that data too, if the data are manipulated, not to a huge degree, and tracking takes place over time to build up the database. Measuring patient response to changes in pain management is, of course, important and part of something that we have to remember how to integrate in our work. And we hope to submit a demonstration and dissemination proposal to ARC in later this year. So that's our goal. So thanks, that's our project. Thanks again to our funders, and here's some contact information if you'd like to follow up.
I think we need to go to the introduce Dr. Kaminsky. Dr. David Kaminsky is an associate professor at the University of Vermont Larner College of Medicine, and his research interests center around pulmonary physiology, pulmonary function testing, lung mechanisms in asthma, and COPD. His presentation today is entitled Feasibility of Home Monitoring of Lung Function and Symptoms in Patients with COPD Exposed to Wood Smoke at Home. Dr. Kaminsky.
Thank you, Janet, and thank you, everyone. It's really nice to be here. I think I presented some of this presentation previously to some of you, so hopefully it will still be new to others, and I'm going to go ahead and share my screen. And if you could just confirm for me that you can see the screen. Okay. Yep. Thank you. Great. So again, thanks so much. I was very lucky to get pilot funding from the NNE-CTR for this project. And I did this together with Kelly Cowan, who's one of our pediatric pulmonologists here at UVM, with Sean Wayne, who's one of our pulmonary fellows who's just graduating this month after finishing his training, and with Laura Paulin, who's from Dartmouth, who's an expert in the area of indoor and outdoor air pollution. And this project stems from the fact that we know that among patients who have chronic obstructive pulmonary disease, that one of the risk factors for both developing the disease and having exacerbations of the disease is air pollution. And this is a recent review from the European Respiratory Society that shows that air pollution and other chemical components of air pollution are highly associated in terms of odds ratio and hazard ratio with the development or the exacerbations of COPD. And among these components, if you look at the second line, is ambient PM 2.5. That stands for particulate matter that's 2.5 microns in size. And what I mean by that on the left-hand side is you can see that PM 2.5, which is in the pink little dot there, is a very, very small particle in this particular diagram compared to a human hair or a grain of sand on the beach. And the reason this is critical is because these are the size of particles that can make their way down deep into the lung. If you look on the right-hand side of the figure, you see that the particles that are less than 5 microns in diameter generally make it down to the lower airways, and less than 2.5 microns make it down to the deepest parts of the lung, which is where they can actually interact almost directly with the bloodstream in terms of the cellular interactions that take place at that level. And we know from an old study in 1993 that PM 2.5 concentrations in the air are highly associated with mortality. This was the famous six cities studies that was published in the New England Journal in 1993, where they looked at over 8,000 Americans who resided in 6 so-called representative cities, and they're listed there. You can see them, Watertown, Mass, Harriman, Tennessee, etc. And if you look at the graph on the left, in each of those cities, there was an average exposure of fine particles that went up, getting all the way up to poor Steubenville, Ohio, and the rate ratio for death increased accordingly. And this was after controlling for many different factors. It was actually interesting on the basis of this study that the American Lung Association sued the EPA, and this resulted in the national ambient air quality standards that we have today. Now, one of the sources of PM 2.5 in the home is actually wood stoves. And this is very pertinent to northern New England, where a lot of people burn wood to keep themselves warm during the winter. And that's why we focused on that aspect during our study. And these are some data from Laura Paulin and her colleagues when she was at Johns Hopkins that looked at indoor air pollution with regard to PM 2.5 and also nitrogen dioxide. And they looked at the odds ratio of patients with chronic obstructive pulmonary disease having an exacerbation. And you can see on the left-hand side of the curve, the two data points there show PM 2.5 for the main living area in a circle or the bedroom in a square. And you can see for PM 2.5, the odds ratio was greater than 1, meaning these patients were at risk for having an exacerbation if they had high PM 2.5 in their main living area. On the right-hand side, the same was true of nitrogen dioxide, but only if the levels were high in their bedroom. And recent data show that wood stoves do contribute a lot of this pollution in the home, particularly as PM 2.5. These are data from a study that looked at 3 different areas, 3 different populations that lived in Alaska, Navajo Nation, or Western Montana, all in the US. And on the right-hand side, you can see that there were varying levels of PM 2.5 in the homes. And on the left-hand side, they were able to correlate that these levels did associate with the quality of the wood stove that was in use, going from low to medium to high quality as you move left to right in those photos there. So because of this, it was noted that if we can swap out these old wood stoves for new ones, we might be able to reduce PM 2.5 exposure. And indeed, this was proven in another study that came out of Montana, where if you look at the dark bars, those were the average level of PM 2.5 in the homes before the swap out. And then in the white bars after the swap out, when they provided newer, more fuel efficient, cleaner stoves for people. So this really does show that an intervention like this can work. So the hypothesis for our study is we wanted to gather data like this in our community in northern New England. And so first I wanted to be able to show that it was feasible to do so. And in particular, not only measure 2.5, but also measure lung function in the home, because I'm interested in pulmonary physiology, and I want to know if there was an association between the 2.5 levels and lung function, and more importantly, exacerbations in quality of life. So this was a feasibility study. We had three specific aims. One was to validate the use of home spirometry, which I'll show you in a moment, to determine if it was feasible to measure indoor air quality, especially PM 2.5. And then finally, a more exploratory specific aim was to look at the feasibility of another test called oscillometry, which is gaining traction these days as a more sophisticated way to measure lung capacity and lung function without much effort on the part of the patient. So this study involved a practice site down in Barre, Vermont at Central Vermont Medical Center, where we recruited participants from a primary care office and a pulmonary office. And if they agreed to participate, we did some measurements on day one in the office setting. Then we sent them home for 7 consecutive days of monitoring and measurement. And then they came back on the last day, the second study visit in the office, to make measurements once again and return the equipment. And on the left-hand side, we used a portable spirometer. You can see how small it is, and it gives you typical data from spirometry, such as the FEV1 and the FVC. And on the right-hand side, we used a new portable device called an oscillometer. You can see it's also quite portable. And the way you do this test, unlike spirometry, where you have to blow hard into the machine, for this test, you simply breathe quietly. And it imparts a signal into the mouth, which gets transmitted down to the lungs. And then using some mathematical analysis and modeling, you can compute what the respiratory resistance is and other components of lung mechanics. And that's shown by the fancy graph down there on the right-hand side. And meanwhile, we assessed patients by a COPD assessment test, which assesses them for symptoms, quality of life called the St. George Respiratory Questionnaire, their level of shortness of breath using the MMRC dyspnea scale, and we asked them to keep a diary at home to let us know what activities were going on, how they felt day to day, and so forth. And this is just showing the typical day of the office visit. I or Sean would meet them in the office, and on the table there on the left is the oscillometry unit together with an iPad. In the middle, you can see the purple spirometer, and on the right-hand side, mounted on a piece of wood, is a device called the Purple Air, which is a device to measure home air quality and outdoor air quality for that matter. So we would get spirometry data that looks like this. You can see it's time-stamped. These data were collected during the winter of 2023. And we can see the date and the time of their measurement. We asked participants to measure their spirometry twice a day. And this device was Bluetooth enabled, so we could monitor real-time how they were doing. And if there were any major problems, we could contact them to adjust their technique. And the oscillometry data was likewise collected in a similar fashion. And you can see there's a whole host of data printed out there where the various symbols X5 and R5 mean different components of the lung mechanics. And the indoor air monitor, again, was a Purple Air device. You can see it on the right-hand side. This device is used around the world. And what's really interesting is you can go online and see where people are monitoring real time. At the time of this study, I quickly took a look at Burlington, and you could see there are 4 people in the immediate area that were monitoring their indoor air quality with various values as seen. These values were the parts per million in the 2.5 levels. So this was the cohort of our patients. I know it looks small, and this is one thing we learned in terms of a feasibility study. This took a lot of time to work out the logistics and get people interested in doing this, but we were able to make measurements on 8 people. You can see they were on average 70 years old, and half were men and half were women. A few of them were still smoking. Most were prior smokers, but they had a substantial smoking history of 45 pack years. And they had a lot of symptoms of COPD. Their CAT score was 13. Anything greater than 10 was significant. They were short of breath. Anything greater than 0 significant, and their average score was 1.25. And their FEV1, which is the fundamental measurement of spirometry, was only at 65% of the predicted value, putting them in the moderate range of physiological abnormality. And then the other two numbers you see there, R5 and AX, come from the oscillometry. R5 is resistance. Anything above 1.5 or 2 is elevated, and you can see that the average value is quite elevated, which goes along with having high airway resistance in an airway disease like COPD. And AX refers to a complex component of lung mechanics that relates to the stiffness, the apparent stiffness of their lungs. And anything over around 10 or 15 is elevated, and theirs was on average 24. So all of these measurements were compatible with them having moderate to severe COPD. And what we found were data like this. So here I'm showing you data from 3 separate participants, numbers 6, 7, and 8. From the top, we see their CAT score. The second row is their MRC score, which is shortness of breath. The third row is their FEV1 from the spirometry, and the fourth row is the PM2.5 over the course of the week. I think the first thing to notice is that the PM2.5 levels in these 3 different people followed similar patterns of spikes, spiking levels, then coming down, going up and coming down. And we learned from their diaries that this happened when they were opening the wood stove to refill it with wood. And anyone who has a wood stove knows that when you open the stove, a little cloud of dust and smoke comes out. And sure enough, that's what was happening. We asked people to place the monitor in the room where they spent the most time, but not their bedroom, and not right immediately next to the wood stove. And then you can see that people had various levels of symptomatology. That's the top row, the CAT score. For example, the person in the middle had a steady value of 12, and it didn't change over the course of the week. Likewise, for the shortness of breath scores, this was very steady in all 3 participants. Notice the scales, though, the y-axis scales are slightly different. Their FEV1 values varied up and down, but there was no clear association with the PM2.5. But remember, the FEV1 values and the oscillometry values were only measured twice a day, once in the morning and once in the late afternoon, evening. But we were able to get good measurements. And here are the oscillometry data for the same 3 participants. You'll see the same PM2.5 patterns down below. And what you find here in green at the top is the resistance at 5 Hertz going up and down. The reactance at 5 Hertz, I didn't mention reactance before, but that's another measure of the lung overall stiffness. The AX value, which I did mention before, you can see that in the 3rd row. And once again, these values are varying up and down, up and down. Subject 7 was very interesting because if you look carefully at the AX values or their mirror image, the X5 values, these did seem to associate with the PM2.5 in the direction we might expect if particulate matter was making their lung function worse. So even though we didn't have high time resolution on the lung function, in this particular case, it looked like there was a pattern here that was coinciding. So I just wanted to mention that we have presented these data now once to you already in a different forum. Last summer, I presented these data at an oscillometry conference in Montreal. And then I just came back from the American Thoracic Society meeting in San Diego last month, where Sean, our fellow, presented these data at the international meeting. And the data were received very well. People were quite excited that we were able to show that we can, in fact, make these measurements in a reliable way at home. And we hope to carry this project forward, as I'll show you next. So in summary, we found that we were able to do these measurements, so the project was feasible, although we learned a lot about barriers that needed to be overcome. We did see this important pattern of periodicity in the PM2.5, which we need to pay more attention to in subsequent studies. And although we didn't see clear associations between these levels in symptoms and lung function, we realized the data are very limited in terms of the overall monitoring period and how frequently lung function was being measured. And one thing I was quite excited about, even though it was hard to find a few people, the people who were participating were very enthusiastic. When we met them on the second office visit, some of them didn't want to give up their air monitor or their machines because they felt like they were in touch with their lung disease. And that's one of the things that's so great about this kind of study is people become empowered to really understand what's going on. The big barriers, of course, we found were it was very hard to arrange all of this logistically. Luckily, the pulmonary clinic at CBMC was very generous with time and personnel and giving us space to do this. And one thing that we ran into was there were a couple people who literally lived up in the hills and had no internet access. So we couldn't do real-time monitoring of some of their lung function or their PM 2.5. So we had to rely on downloads after the fact. And though we got the data, it's not as ideal because it would be nice to identify problems during the monitoring period and try to fix them. And so we have to be careful of that moving forward. Of course, that puts a certain bias into the population being studied, those who have access to internet. So in the future, I want to try to fill in some gaps. It's interesting, we don't have a lot of data on COPD prevalence in the rural northeast part of this country. So putting spirometers into the hands of primary care and at home should help solve this problem so we can better identify COPD. Laura, Dr. Pollan at Dartmouth and I have been in touch multiple times since the study started about future directions regarding her work. And one of the things we hope to do is put these devices into the homes of people this upcoming winter, starting 2024, for prolonged periods of monitoring, hopefully at least 2 months, so that we can get more longitudinal data and get better correlations with symptoms. Because of this study, the American Lung Association called me and said, would I be interested in helping on an indoor air quality grant initiative? So I've been on that committee, and the ALA has now developed a brand new grant initiative focusing specifically on indoor air quality. So now that that's available, I hope to apply to get funding to help carry on this study in the future. And then finally, I want to share some exciting data with you, and that is how we might use these devices at home to not only monitor disease, but predict exacerbations. On the left-hand side are FEV1 data in patients with COPD. Looking over time on the x-axis is weeks from when they had an exacerbation. And you can see when it changes sign from minus to positive, the exacerbation happened at day 0. Well, if you look closely, the FEV1 was relatively stable, but started to fall about 2 to 3 weeks before the exacerbation occurred. So theoretically, it's possible to identify these kind of trends in people and alert them and hopefully modify either their exposures or their medications to try to avert such an exacerbation. And on the right-hand side are data from Cognita, which is the company that makes the device I was using. I'll be working with them on a separate project. You can see likewise here, well before the emergency room visit that's shown in the upper panel, measurements of small airway problems or obstruction were rising well before the ER visit occurred. And likewise, down below, symptoms were trucking along in a relatively stable but variable state, and then started to rise a day or so before the exacerbation occurred. So the oscillometer was able to pick things up multiple days sooner than the symptoms were before the person ended up having to go to the emergency department. So that's where we hope to move this work in the future. I want to thank, of course, Sean, who helped me with this study, Kelly and Laura, who were collaborators. Caitlin was one of our administrators at the Vermont Lung Center who helped with the logistics, and Jonathan as part of the NNE-CTR who helped with the data collection and analysis. And again, thank you so much to the NNE-CTR for allowing this pilot project to move forward. I'm happy to take any questions.
I want to let Connie know that we'll take questions as well.
Okay, Charlie, I see your hand up. I don't know which was first, Charlie or Gary, but I see Charlie's there.
Gary was first.
Gary, go ahead.
Okay, I'll give it a shot. I was curious, is there any indication if the source of the wood, the type of wood, has any impact on the pulmonary complications?
That's a great question, Gary. I don't know the answer to that. people used a variety of wood, but we did not keep track of the specific types or sources. So that's something we should look at in the future. Thank you.
Dave, this is super interesting. Thanks. I wonder what's known about the physiology of if you get a load of these particles inhaled, should it have an impact in minutes, hours, days, or weeks? Because I can imagine if you just have a wood stove and it's up and down all day, there's probably some cumulative effect of that.
Absolutely, Charlie. I agree with you. There's a cumulative effect. So looking at mean concentrations is what most people have done in terms of population studies and outdoor air pollution. I think the answer is probably both. I think acute large exposures, like we saw this past summer with the Canadian wildfires, the days that the levels were high were days that the emergency room saw more visits. So people with asthma or very reactive disease will respond within minutes to hours, probably. But I also think there's probably longer term effects in terms of the toxicity of these particulates, and more important, what they carry on them, what biochemical effects they're having, cellular injury or inflammation, etc. So I think both components will be at play. Nora?
Hi, so I'm Nora Travis. I work for NESCOM. I also am emeritus at Keene State College, and I work with Laura Paulin, but I don't think she's on the call. And I'm going to reach out to her as well. We, in fact, just submitted a publication where we did indoor air quality over the COVID pandemic. And I am excited to see about the movement into at-home physiological measurements. I think that is enormous and really, really important. So my expertise is in particulate matter and in purple air. And I was wondering if you could go back to the slide with the purple air measurements, because I think there might be a slight anomaly.
Sure, you can help me there. Absolutely.
Yeah.
Purple air, as you know, collects a lot of data.
It does.
And I was just showing the PM 2.5, but
yes. Okay. So the y-axis there.
Yeah.
I
all
live
different
in
scales.
this data. Yeah, I with the data retrieval and processing and all the very many steps that are involved, I think I know what the anomaly is. It's not going to change the pattern of what we're seeing here. Like you said, the opening and closing of the doors always results in spikes. I'm actually glad that you confirmed that. That's what Laura and I saw in a previous study, and it is important and remarkable. The increase in acute exposures that happen over the loading time frame. I think the exact measurement here might not be mass concentration, because you reported a very high mass concentration, and I have very little confidence in that based on what I'm seeing here.
Maybe I could connect with you offline and we could go through it in more detail. I'd be very interested to learn about that.
Yes, yes. So I wanted to just speak up because I'm actually invited. I hope this doesn't, I hope I get invited back, but I wanted to make sure I got your information to talk to you.
Thank you so much. I really
An
appreciate
easy fix.
Connie, do you have any questions about the work?
No, I'm all set.
Again, I can't hear you.
Okay, I'm sorry. No, I don't have any questions. Thanks.
Okay. Eula, can you take over?
Sure. I just wanted to point to the chat in case anybody's not looking at it. We have one more outstanding, topic that we're going to be discussing as our closing seminar for the spring series. It's called Large Language Models in Healthcare. Is Chat GPT a friend, a foe, or the tip of the iceberg? So if anybody's free this coming Monday at noon, that's going to be our final seminar. And I think we're going to have quite a lovely turnout for it. So Also wanted to do a shout out for all three presenters. You were phenomenal today.
Yeah, I was going to say the same thing. It was really, really very interesting presentations. Yeah, it kind of makes me wonder if I should use my wood stove as often as I do. So yeah, thank you for everybody, and thank you for everybody for showing up. And I hope you all have a great weekend. Yeah, thank you.
Thank
Thank you
you.
very much.